Any comments from staff concerning this? Okay, do we have any public comments on this? All right.
Yes, thank you very much. This is Ann Donnelly from Project Inform. We'd like to thank the legislature for considering this proposal. We think it's really important right now to modernize these eligibility criteria because in the past, the program historically started in 1987 with a very different population. Then it was mostly men who have sex with men and very few people who had dependents at that time, but obviously changes in the epidemic and also changes just in the marriage and adoption and family rights in the LBGT community make it really necessary at this point to change that eligibility and ensure that we have a family size criteria. And we want to work with the State Office of AIDS to develop the right criteria to ensure that our ADAP clientele is fairly served. The cap issue, right now, as you said, it has a $50,000 cap, and we think that this makes sense to increase it just a little bit. The National Alliance of State and Territorial AIDS Directors estimate that's about 447% of federal poverty level. We believe it should go to 500% of federal poverty level, and that's consistent with other high-cost states with their ADAP program. And actually, I wasn't aware that any ADAP programs have asset requirements on them. That could be true, but I've looked at the NASTAD survey, and I don't think they do. The other reason that we think this is really important is we don't think that actually the caseload would increase very much. We did a very, very rough estimate. It looks like maybe the program might increase by about 1%. The vast majority of the people on this program are well below that income level. But we think it's critically important, especially in light of Covered California, because right now it's almost impossible for a person with a chronic illness to be able to make an informed decision and about which plan is best for them. And about half the plans in California have all of the antiretrovirals tiered at a very, very high cost-sharing rate. And the person might not be aware that that was the plan they were choosing. The coinsurance can go as high as 40%. So we're very concerned. Most people at this income level will have insurance, but they may need help with it. So for the very small percentage who it will help, it will be a significant help and actually allow them to access insurance.
Thank you.
Thank you.
Good afternoon. My name is Phil Curtis. I'm the Director of Government Affairs at AIDS Project Los Angeles. I want to thank you for considering these two OA-HIP issues. We are also here to support updating ADAP eligibility and also coverage for cost sharing in covered California plans. Thank you very much.
Thank you.
My name is Aaron Fox from the LA Gay and Lesbian Center. We also thank the legislature for taking up these proposals and believe that for people with HIV who are currently Ryan White ADAP-only clients to effectively move into full health insurance coverage, which is something that we desperately want, there does need to be a full wraparound of the OA-HIP program with Covered California. The Health Resources Services Administration has already green-lighted this and has said that OA-HIP or ADAP can fully wrap around Covered California and provide increased support for eligible out-of-pocket costs. And for people with chronic conditions, especially HIV, we would never want cost to be a barrier for someone to get care through their health insurance. And so if OA-HIP is able to completely wrap around Covered California, we know that people will move into full health insurance faster, and they will be able to get the services and medications that they need.
Okay, we're dealing, thank you very much. We're dealing with ADAP eligibility and family size proposal right now. Okay.
Oh, I thought you took them together.
Well, they haven't given the other presentation.
Oh, okay.
They will in a minute. But we've heard you. Thank you.
You're welcome.
That's good.
Sorry, Chair and members, Kathy Mossberg with the San Francisco AIDS Foundation. We will just cover the one then, and we'll be back for the second one.
You want to give us both? Go ahead and give it to us.
Okay, I'll do it for you.
Yeah.
We certainly want to associate ourselves with the comments made on both proposals. We do support both those proposals, and we encourage when it's an appropriate time for this subcommittee to support those and put those forward. Thank you.
Thank you.
Let me separate my comments because they are two separate issues. Beth Capel on behalf of Health Access California. We think that this ADAP eligibility is an important updating of this program in light of the Affordable Care Act and is appropriate to go to a somewhat higher income level than the assistance in the Affordable Care Act, given the very high cost of living in most of California and the fact that we would have appreciated a somewhat more Affordable Care Act in terms of what consumers pay, although we are very happy to have what we have. So we would encourage the committee to adopt the proposal.
Thank you. Okay. Do we have any comments from the administration concerning the proposal?
Sure. This proposal has several different components to it, redefining the income used to calculate ADAP and OAHIP eligibility from federal adjusted gross income to modified adjusted gross income, or MAGI. This change would bring ADAP's income measure in alignment with the income measure MAGI that's used by ACA programs, and it would facilitate ADAP's ability to calculate which of our clients should be eligible for other ACA programs, such as Medi-Cal expansion in Covered California. The other component is increasing the existing eligibility cap of $50,000, which is approximately 423% of the FPL based on 2014 FPL levels, to 500% FPL, and we would be happy to provide a cost estimate for that if requested.
Okay, sounds good. Any other comments from the panels? Okay, any other comments from our staff? From our legislature? Any? No? Okay, then. Thank you very much. Let's move on to item number 5, which is the Office of AIDS Health Insurance Premium Payment Proposal.
According to the agenda, advocates have submitted a proposal to require the Office of AIDS Health Insurance Premium Payment Program to cover all copays, coinsurance, and deductibles incurred by eligible people living with HIV or AIDS who are enrolled in private health insurance through Covered California. Currently, OAHIP covers private insurance premiums and copays and deductibles for ADAP formulary drugs. And again, we've just received the details on this proposal recently, so we're not able to provide cost estimates at this time.
Staff have any comments on the proposal?
We would like to thank the Assembly staff for providing an excellent summary of our response in the agenda today. The administration considers this approach part of a larger discussion on state-only programs and the impact on them of ACA implementation. Our estimate assumes the payment of medical out-of-pocket expenses would start January 1st, 2016. In order to implement this programmatic change, we would need to develop a request for proposals and enter into a contract with a third-party administrator to pay for premiums and eligible medical out-of-pocket expenses for OAHIP clients. It's not clear at this time whether additional administrative costs would be incurred for this approach and whether there would be costs to other state programs and departments. We estimate that between 25% and 33% of eligible ADAP-only clients would co-enroll in Covered California and OAHIP in the first year of implementation of this proposed policy change, compared with an estimated 7.2% of ADAP-only clients who will co-enroll in Covered California and OAHIP in fiscal year 15-16 if medical out-of-pocket costs are not covered. Given these assumptions, we project that the cost of paying medical out-of-pocket expenses in this proposal would range from $1.8 to $2.4 million in fiscal year 15-16, but would result in a net savings of $6.3 to $9.4 million in fiscal year 15-16. These estimates assume the current rebate return rate. We do not expect that we would have any additional information besides what we have presented to date and is in the agenda until if we were asked again at around the time of the May revise.
Okay. Okay. Any questions? Okay. Do we have anyone left who needs to make a comment about this?
Thank you again, Ann Donnelly from Project Inform. And again, my colleague did a great job covering everything, but I think just a couple of things I wanted to add. One is that we do think that the program, as Dr. Mark said, is likely relatively cost neutral because it would be assisting people getting into insurance, and then, of course, the AIDS Drug Assistance Program wouldn't have to supply all of their drugs. One other really important point is people living with HIV are one of the few people who are actually moving from a system of care into a new system of care when they enroll in Covered California. And working directly with clients, I've really seen that these out-of-pocket costs, which can be quite high, are a real barrier to people being able to actually afford the insurance that would make a really big difference in their health and their outcomes, and actually makes a big difference in public health because we know that effective HIV treatment and keeping people in care is by far our best prevention tool for decreasing new infections. So thank you.
Thank you.
Beth Capel for Health Access California. just to remind the committee that in addition to the cost of premiums that people incur in covered California, which ranges from 2% of income to 9.5% of income, they also face a maximum out-of-pocket cost of $6,350 for an individual and $12,700 for a family. Very few of us ever have costs like that in a year, but people with HIV and AIDS and other people are people who would face those kinds of costs, perhaps even in the month of January, just to pay for their first month's prescriptions. So we would support this proposal because they face these extraordinary costs that most of us do not face. Thank you.
Thank you. Okay. I want to thank the staff for these proposals. I think as we look at this, the adjustment in terms of family income as well as the concern for out-of-pocket costs makes it a good proposal. Hopefully we'll get the actual data concerning the proposal in terms of what it will cost, but it's good to see that we're being sensitive to this growing area of need. That brings us to the issue number 6, which is genetic disease screening program estimate.
Madam Chair, I'm Daniel Kim. I'm the Chief Deputy Director of Operations for the Department and also the Acting Deputy Director for the Center for Family Health. With me is Chris Nelson, who's the Assistant Deputy Director for the Center, and she will be presenting the GDSP discussion.
Thank you.
Great. Thank you very much for asking us to present today and explain the proposed fee increase to the prenatal screening program. The department has proposed a $45 fee increase for the prenatal screening program, bringing the fee from $162 to $207. And the reason for this is because actual costs have exceeded actual revenue for the past several years. There are two major factors that have played a role in this issue not coming to light sooner. One is how we calculate the caseload in the past, and two, the delay in collecting revenue. Over the past few years, our actual caseload was less than what we had projected, and also our actual costs were less than what we had projected as well. However, the variance between the actual and projected revenue was much larger. For fiscal years 10-11 through 12-13, the average variance between budget and actual expenditures was less than 3%, but average variance for revenue was about 12%. It can take several years to collect revenue, and so it took some time to determine the actual revenue for 1 year of services under the program. And while the reduced Medi-Cal rates have reduced our revenue for the past years, impacting the cash flow, we will receive a refund from the Medi-Cal program later in 2014, and this refund was included in our calculations for determining the $45 amount. In this estimate, we revised the caseload projection methodology so that we have a better projection for both expenditures and for revenue starting in fiscal year 13-14 onward. However, we continue to have a shortfall even with the revised caseload projections. We have implemented changes to reduce costs and to better tie costs to our caseload, but we cannot fully address the shortfall with reduced costs alone. We need to ensure that the program services are state-of-the-art. The $45 fee increase includes two components: $26 to right-size fiscal year 14-15 and ensure a prudent reserve, and $19 to address the shortfall from prior years over the next 2.5 years. And with the advancements in technology, we will need to revisit the fee structure at that time. Just for your reference, we looked at prices that private labs in other states charge for just the laboratory portion of the work, and the lowest price that we found was $400. That price would only cover the lab processing, and if the woman had a positive screen, she would need to get more additional service such as amniocentesis or genetic counseling that could cost up to $1,000. And our fee of $207 would cover all of that. In preparing this proposal, we examined the impact of fee increases in the past to see if this fee increase would have an impact on participation in the program. In the past, we did not see abnormal caseload changes when we implemented fee increases. We saw that program services being state-of-the-art was the critical factor for participation, not the fee. In early 2009, prior to adding the first trimester screen to the program, as what was happening in private labs, we saw that participation had a steady decline over the course of a year. And as I stated, outside labs were providing the services and the state was not at that time. With the addition of that service in the first trimester screen to the program, we saw an increase in 23% of participation over 6 months, and that included a fee increase. So even with adding a fee increase, we saw a dramatic increase in participation. So therefore, we do not expect to see an impact on caseload due to this fee increase. And your last question was addressing the difficulty that we have in collecting these fees and also working with Department of Managed Health Care. We do experience some problems collecting the prenatal fees from insurance companies. We don't fit the typical in-network model that providers use. Oftentimes the insurance companies want to negotiate a lower rate with their in-network providers, and since we're the only program in the state that provides this service, we don't negotiate that. Our fee is set in statute, and we don't fit that model of alternate providers being allowed, available under a program. There's existing law that requires insurance companies to cover the prenatal screening program. However, they can exclude copays and deductibles to reduce the amount that's actually paid to us. So that really is the crux of the issue that we have there. And the specific coverage can change from individual policy to individual policy. So we can't make a blanket statement that says this insurance company will have a deductible for the prenatal screening program. It's really based on individual policy to policy. So it creates a substantial challenge for us when we don't receive 100% of the payment. We would have to then go through that individual woman's policy to know exactly what's covered and what's not covered under that program. We have worked with Department of Managed Health Care, and they have facilitated communication with specific HMOs to resolve some specific issues, and they have been very helpful to us. They've also helped us to understand the intricacies of the industry so that we can best use our resources to collect revenue. But at this point, we don't see the need for a legislative fix to this issue. One of the challenges is also the jurisdiction, since many of these insurance companies are outside of California. So we continue to work with Department of Managed Health Care to identify strategies and resolutions to the problem.
Thank you. Any comments from Finance or LAO? No?
I have a little hard time getting my mind around a cash flow problem, which is essentially a problem of time when the money comes in. Why you would need to bring in more money rather than address when the money comes in to solve the problem. Because, I mean, if you're collecting money on an ongoing basis, you're going to collect more than you need for the cash flow, and then it will begin to accumulate. So it just seems like a long-term solution to a temporary problem.
So the cash flow issue was really a challenge in identifying exactly what the revenues would be for a year. So assuming that we collect everything on time, then we compared that revenue to the expenditures. And even with that, we saw a need for an increase. So it's not a cash flow issue per se, but the cash flow was a factor in identifying the problem.
Assemblymember Chesbro, the program pays its vendors before we collect all the revenue. So we're always in a situation where we have to pay out before we get the revenue.
So if you had enough money to get ahead of that problem, that would be a temporary, that would be a one-time fix, as opposed to collecting money every year forward to solve that problem. Once you had enough money to have that pool of reserve or whatever, it seems like it's a timing problem and a reserve problem, not a revenue problem.
Yes, I can. You're correct in that sense. That's why we are proposing the fee at the rate we are, to basically stabilize the fund over a 3-year period. Otherwise, in your situation, if we just had the one-time fix, the fee increase would be significantly higher in the first year. The fee increase of $45 will stabilize it over the 3-year period. Now, there are going to be other factors that we will have to consider in that period. there are a number of variables in play. In the event that the fees are too high in the future, there's always the option to reduce fees, which has happened in the past.
Okay.
Aye. Well, it just seems to me that once you fill a pool that you need to pay your bills, that regardless of whether it's too high or people are going to quit the program, you shouldn't be charging for people for something on an ongoing basis that it will get fixed in shorter time frame. It's just hard for me to, and I'm sure we can come back and say, oh, now we've got too much and we'll lower it, but it just seems to me it's a broad solution to a very specific problem, that is related to time frame relative to when the money comes in.
There is part of the fee increase is to address the variance between revenue and expenditures in the past years. Even if all the cash flow and timing aside, even if we had everything on time, there wouldn't be sufficient revenue to address the expenditure. So part of the fee increase is to address that the deficits over the few years, and then that piece would not be necessary in the future.
Well, my question was specifically that portion of the increase that was being attributed to the cash flow problem, not the other part of it. So anyway, that's where it looks from where I sit.
Okay. Any other comments, questions? Any public comments? Okay, I guess not. All right. I agree with you too. I mean, I thought it was a cash flow issue. Now you're telling me it's a cost factor. I assume so. Hopefully, we'll get the data that helps us to understand that a little bit better. But it seemed like it was an issue of timing when money comes in, and if that's the case, it would be unreasonable to charge people more for services. And the services haven't increased, and the cost of the services haven't increased. When you get your money, it becomes a problem. And so hopefully there's more to it than what we hear. Okay? All right, let's deal with item number 7. Tobacco control program reductions.
Madam Chair, members, Drew Johnson. I'm the Acting Deputy Director for the Center for Chronic Disease Prevention and Health Promotion with the Department of Public Health. Each year, the Department of Finance projects the amount of revenue that the state will receive from the imposition of tax on tobacco products. As a victim of our own success, we've seen the trend kind of go down as the state, local, and community partners have done a wonderful job in both cessation and tobacco use prevention. California is second only to the state of Utah in per capita smoking. For the current year, though, there was a projection of a little bit of a blip. We saw an increase in the tax revenue from the imposition of the tax on products. We treated that in the current year as a one-time only. It looked like an aberration data point, and we are projecting through the Department of Finance for the budget year for that to actually decrease again. So we made budget adjustments in the current year that would augment resources on a one-time basis only, and thus that which is going to go in, we're projecting that which will come out in about $3 million for the budget year. We funded in the current year in one-time only, for example, expansion of some media markets in some smaller rural areas of the state, Chico, Redding, Eureka, El Centro, Salinas, Monterey, and that will come in and come out. And then we've also let some small contracts to CBOs in disproportionately impacted areas of the state where tobacco use is excessively high. So we saw this one-time blip, and then we see this one-time, it's going back now, resurrecting itself on a downward trend.
Okay. Any questions? Yes.
Just as a matter of curiosity, do we have a sudden upsurge in temporary smokers? It just seems really strange.
I'd like to defer to the Department of Finance. That actually makes the projections.
Department of Finance?
John Botchgalupi with the Department of Finance. The process, first of all, one important point to note is that The numbers are updated with the May revision of the governor's budget, so the numbers are viewed more than once throughout the process. And also, too, another important factor to note is that there are several programs that compete for Proposition 99 funding, or I should say are allocated Proposition 99 funding. And I think that the universe of programs receiving the funding sometimes, I think, figures into some allocations received by programs across the universe of funding from Proposition 99. But certainly we'll look into I can provide a more thorough, exact, accounting of the process, as of last fall regarding the allocation of the funds to the department. I can follow up with committee staff.
I don't know if you answered Mr. Chesboro's question. He wanted to know where do we find temporary smokers? Where the $3 million come from? Do we import them and then send them home?
No, finance didn't import them. So, but we can explore the senator's question further.
All right, sounds good.
And Adam Dorsey, Finance. So one of the important things to note about this source of funding is that it's related to surcharges on tobacco products, and so as fewer people smoke, the revenue does go down for the fund, and that's a problem not only for our state but for other states as well that levies, similar fees and taxes. So
well, that's the easy part to understand. That's
Yeah.
the easy part to understand. The hard part to understand is a blip. So
we'll figure that out. We'll
Correct.
call
We'll
them,
work
have
with
them
subcommittee
volunteer and
staff.
tell us they were closet smokers or something? Okay.
Yeah, we'll find them.
You'll find them?
They exist. Yeah.
Okay, sounds good. Do we have any public comments on this? Okay. Yes, Mr. Dickinson.
When I was chairing Sacramento First Five, I was fond of saying that I wanted people to buy as much in the way of tobacco products as they could possibly afford, just not use them. But I would just submit that the decline in revenue over time here is not a problem. It's a success. Mm-hmm. And I think we should keep in mind that the object of the exercise here is to reduce and prevent smoking. So, but I wanted to ask a question that I'm not sure I got a full understanding of. The $3 million blip that's been expended in the current year for programs, is that right? Grants have been made with that $3 million, and so is that right? First of all,
Yeah, one time only. Yes, we anticipated.
So
this to be
those who
that way.
received, I'm sorry, I didn't mean to cut you off. Those who received the grants understood that they were 1 year, one time only.
Yes.
All
We
right.
didn't look this as a new baseline or a new trend with that single data point.
And you told the grantees that you expected they were one-time only grants because you anticipated that there would not be this blip as a continuing
Right,
trend.
that's my understanding, yes.
I see. Okay. Thanks.
Okay. Any other comments? Okay. That takes us to item number 8, public health reinvestment. Okay. We're going to ask our LAO to briefly present the issue, and then we'll have them move so that our stakeholder panels can be up here. Okay?